Okay, last section, we're doing the postpartum techniques. And I just want to talk to you about a few things that people don't normally talk about. So, right after a woman has her baby, they do the fundal massage. So, they want to get the uterus back down, and it's done immediately postpartum. So this is done by the nurses generally, and they'll hold the bottom of the uterus right above the pubic bone and wedge their hand in there while the top hand will push down on the fundus, which is the top part of the uterus, and push down and knead that away and try to get it back down to like the size of an apple, how it used to be. So it might feel like organs are, going to prolapse. So that's why they put the hand down there. So, just to kind of keep everything tucked in and knead it down. So I believe I shared a video of this already. So I'm going to put it into order as soon as I can. All right. So the rest of it, though, I wanted to say that happens naturally every time the woman breastfeeds. The uterus will cramp. They call it after pains. And with each subsequent birth, those after pains get stronger. But the first time, you might just feel like you're having what would be period cramps whenever you're breastfeeding, and that helps your uterus to contract and then get the uterus down. So sometimes instead of doing a fundal massage, they might do Pitocin, an injection in the thigh. Another thing people don't talk about is what your stomach looks like right after you have a baby. Usually for about a week, you still look pregnant. I think a lot of women expect their stomach to be flat right after they have the baby, but you look pretty big still for about a week. And the first time you look down and see your stomach, this really isn't that bad of a picture, but it was the only one I could find of the extra skin there. So it'll look really loose and wrinkled, and we have a technique that we can do to help tone this skin and help it tighten up, which it will do naturally. It won't stay like that forever. And in fact, well, I'll talk about that a little bit. I was going to talk about the linea negra, the stripe that goes down the middle. That sometimes can take a year to go away, the stripe, but the loose skin will tighten up fairly quickly, and we can just do a little bit. So the description is on there, but let's just take a look at the video and I'll explain it.
So you find the ribs, and then I usually will start at the belly button and place your finger, and then you're going to hold the skin, hook your finger, and then drag it. Place, hook, drag. So it should feel kind of like a little burning, not bad though, but. And then when you're done, when you get through the whole thing, it kind of gives this warm sensation all the way through. I just try to keep my hands in a normal alignment so I'm not all twisted in my wrists and hands and things like that. But you can teach them how to do it to themselves as well. And this is for when there's excess skin and you're trying to tone that. Until you get all the way out to the outer edges by the ribs. And then, of course, you can't see the redness on you because of the tattoos. But it should look like kind of like a bullseye. And you can also make like little commas using your fingers or your thumbs, whatever you want, and just getting it like up under. So it's superficial, but you're you're going in that crease underneath the rib cage, making little commas. Right under the rib. And you can do it across the iliac crest too. So just do a couple times on each corner. So that'd be kind of like a step one. How I do it with a vacuum cupping tube. I think it's easier because then you don't have to use full suction and you can control it. I'll show you how. So we can do some gentle, I wouldn't do anything deep, but we can do some gentle massage, trying to help the intestines finding their way to fold back into place around the organs. After the baby's out of there, everything kind of has to get back into place again. So we're always going to go clockwise because we have the descending colon, the transverse colon, the ascending colon. So we're kind of following that pattern, even though the intestines may not be lined up completely at that point, and just kind of encouraging back to center cupping. So the big cups draw a lot of skin in and can be pinching, so we don't want to do that. So I use a little cup with a little suction, and you can control it with this pump. So I actually like doing it the other way so that my right hand's doing the work, or my dominant hand, so it might be your left, but so I can just add like a half a pump, and if I let go, it lets the suction go. If I do it too much and it sucks up and it stays that way, so as soon as I let go, it lets go, but if it doesn't, then I have to use the side of my finger to pop it free. So I don't want to suck so much up that I have to do that to pop it free. I just do like a half a pump, enough to hold it, but if I let go, it just falls right off. So once it's on, I can do the same thing. I can start down by the belly button, and then I can very gently now, like it's very, like if I pull any harder, it'll just pop right off. So it's very gentle. And then I just work the same circular motion. And I start my circle so that I'm going clockwise. It's not deep enough that you're going to be affecting digestion. It's very superficial. And it's so light that if I wanted to, I can actually go over the bone because it's not compressing. So you can work with the fascia in that way. I don't have any lotion there. You definitely have to have a lotion. But I could do the intercostals and just kind of vacuum cup there. Again, if I let go of the pump, it just comes right off. And this is just to tone the skin. I'm just vacuuming ever so superficially. If I need to add a little bit more, I can maybe go up to 3/4 of a pump. But these little light cups, they're really gentle, like you could use it on your face. So using it on the stomach to tone the skin really is a nice thing to do. And if you just kind of vacuum in one place, it'll give that same itching, burning sensation like the finger dry on the skin was doing. And you can also use this later on C-section scars to work on the scar down there. And then make it nice when you're done.
So, diastasis recti, and I have a video about this too, explaining what it is. This is where your rectus abdominis meet in the middle, and how we can palpate and feel, and how to fix it. Let's take a look at the video.
About diastasis recti, and we have our rectus abdominal muscles here that normally we have the linea alba is where they come together. It's that line that goes all the way up and down, and when a woman's pregnant, that turns into the linea nigra, which means that this line gets dark, and you'll see a dark line going down. My husband used to call it my zebra stripe. And when you start getting pregnant and the uterus is getting bigger, your rectus abdominal muscles start separating and they go to the outside. And then after you have the baby, they start coming back together and should come back and connect again. Sometimes you have what's called the diastasis recti, where there's actually a big gap in here, and a lot of women trying to get their abs back post-pregnancy is from doing a lot of sit-ups too soon, and then that's actually the worst thing because it makes the gap bigger. So we need to learn to teach them how to brace it when beginning movement exercises. So just to check to see if it exists, one of the best things to do, and like she could check herself or I could check too, and you just place your hands right in the center, and then you have them raise their head. So if you lift your head up, that makes it bulge up. And then she's nice and tight here, she's never had a baby, so. But what you would feel for is like, can I fit one finger width in there? Can I fit 2 finger widths in there, 3 finger widths in there? How wide is that? And so a little gap is normal after you're having a baby, but if you can get 2 or 3 fingers in there, then we have to be a little bit more careful. So beginning, what they can do is if they're laying flat, I'll teach them how to cross their fingers and use the heel of their hand on each side of their rectus abdominis. And so you'll cross your hands and then dig the heel of your hands in there. And so like above your belly button, you're gonna stick the heel of your hands in, cross your fingers, and brace your abs like that. And then you'll just start off like the first week or 2, just doing head raises. Okay. So you might just do 3 sets of 10 and then rest. And that's like a little mini crunch, but you always support that. Then we might do pelvic tilts. So you just kind of do posterior tilts, and you're doing your lower abs as you're bracing. Then we can do things like, just doing one side at a time. You might do heel slides. So I might even, if she's really weak, help her get her leg up, and then it's easier if you have like a sock on so it slides. And then you brace, and then you're just gonna slide your leg down, and then I'll help her get it back up, and then slide it back down. Then see if she can, then eventually see if she can do it on her own. And then we do both sides like that, or one at a time, but then both. Right, so then eventually it gets kind of stronger. Then you can even try to raise your head as you slide your leg back up. You can also try doing straight leg raises. So if you can just do one up and down, just little ones. Right, and it's all done with the bracing. And so we do that for about 8 weeks, whenever we're getting in and out of bed, whenever we're doing something, getting up from flat back. And if we can't brace it and our hands are full, we need to roll onto our side and then push ourselves up. But the more we try to do a regular ab and squeeze without having that connection, it actually makes it go further apart and makes it worse. And so this can happen from intra-abdominal pressure and weak abs. And then in pregnancy, we have really hyperlordosis muscles back here. And the only thing holding our organs in is our transverse abdominis and our pelvic floor. So we'll work on those too, but just want to make you aware of this situation, how to check for it. And so you don't just feel we have to raise their head up off of the table in order to feel that.
And then hopefully women don't have C-section, but if they do and they have a scar, sometimes those scars can affect the pelvic floor later on with the nerves and stuff. Just like any other scar, they need to be worked on. So, but because it's right above the pubic bone, we can do some different kinds of draping to get down there. And so I'm going to show you a video here next, different ways that we can work on the scar and the different levels of healing. Just know that if a lot of times when people do have a C-section, it's done in an emergency type of situation, and it may not be the birth they wanted, so it can be kind of emotional. So okay, let's take a look. There's a couple things that we can do for C-section scars. So I'm not sure if you can see, we wrote with red pen here, trying to create one. This is actually how I would work on with my client too. Usually if they've done a C-section, they're fully shaved, but I'll just take a washcloth and scoot it down to the pubic bone and it'll be right above that. Obviously this is not for everybody, but if you want to work on it or teach them how to work on it, that's cool. There's different stages of working on a scar, so maybe if it's just post, I might even just do some Reiki, right? I might just put my hands over that with intention of healing. We can do some vibratory techniques where we're just doing vibration over the scar just as a first stage in the first couple weeks. We definitely don't want to do any scar work until it's fully healed. And then there's a point when it's fully sealed, but you still don't feel comfortable working over the scar. Like, it would still be tender to work right on the scar. I wouldn't feel comfortable with it. So where the scar is, again, we don't want to dehiss the scar or pull it open if it's not fully healed. So to do that, we don't go right on the scar, but we go right next to the scar, pin the tissue, and then we can pin and stretch in multiple directions, just doing tensile stretches. We would do that while it's healed. It's not weeping, it's not bleeding. We can see the scab's gone, and maybe it's kind of dark red, and it's not really, but we still don't want to go over it. It's still kind of sensitive at that point. There will be a time when we can go right over the scar though. But in the meantime, we're doing tensile stretches, and we can even go, see, it's healed a little bit better now. I can go on each side of the scar, above and below, and then do a little cross fiber tensile stretches. So I'm not sliding on the skin, in other words. I'm pinning the tissue and then mobilizing it. This works really good with cups, as you can suck up, and there'll be a video after this on that and on IASTM tools, so you can look at that. They won't be on a C-section, but you can use the same concept on a C-section scar. So then once you can work on it and I feel comfortable going right over the scar, I could do things like skin rolling. Generally after a woman has a baby, it's different than when they're hard and taut and everything. So you'll be able to pick up the skin and then do skin rolling. And when you're doing it, you want to make sure that your fingers are very close together, not that they're like out here and then it'll pinch the skin. So your fingers have to be right close together. And then you're going really slow, so I wouldn't want to go and run right through. You have to pick it up and then just ever so slowly roll the skin. And when you're going horizontal with the scar, it's a lot easier than when you're going perpendicular with it. But we're going to mobilize it and then feel how thick is it underneath there, right? You'll be able to feel the thickness of the scar underneath. So then after that, we can get a little bit of lotion. And I do like to do cupping in here just because of the location. I feel like it's less invasive than using my fingers right above the pubic bone. But we can just do some general petrissage.
little motions and just mobilize the tissue in there. And then I like to do the cupping after that, or the gauze saw. If I wanted to do gauze saw, I could use a mason jar lid, or I could use a typical tool, but I like the mason jar lid. And you can just go right above and below the scar and beside it and see if there's any scar tissue in there. And work all that out first, and once that's worked out, multi-directional. So I'm just kind of speeding up for the sake of video. You'd go at a 20-degree angle with lotion and working on that tissue, breaking it up to initiate fibroblast production and lay down new collagen fibers. And that might make the scar look really red right afterward, but that'll go away and it'll feel better later. But then you can go right over the scar and kind of break it up. So first all around and then right over. It happens over weeks of time, not all at once. You can use silicone cups, you can use polycarbonate cups, you can use whatever, but I'll just show on here. So if I want to put it away from the scar to start with, I can pin the tissue right next to the scar and then just pull. So we can lift up. So I'm not going to put my hand there so you can see, but I can lift the tissue up and work multifascial layers. Without sliding the cup, I'm just pulling and mobilizing the tissue. But what I want to do is pin the tissue right there first. So I make sure that I have room for my fingers. So I'm going to pin, apply the cup. I'm only using like about a half a pump, just enough to pull the skin up. So now it's on. I'm going to go back and pin the tissue and then just stretch. I can go away from my fingers and then in each direction, just stretching the tissue. And that's while it's still kind of raw. Then I'm just going to slide it down. So you can't slide it on the skin, but so once it's healed, I can move down and I can actually slide the cup with lotion or oil horizontally with the scar right above, below, and then eventually right on it. Or I can go perpendicular and go back and forth across the scar, working it all the way across. This way, as I'm mobilizing the tissue, you can feel it pull up against the other layers and break up in there. And then this kind of pull through this. And you do a little aftercare, you're just making it nice. Okay, and that's the C-section.
And then these aren't C-section scars, but I'm showing on some video I had other scars just to give you another look at scar work.
We have a scar here. It looks like a little scope hole there. Old scars. What was it? ACL surgery. So they're pretty old now. If you have a new scar that you're working on, and it's healed, but it's still fresh enough that it's not fully healed, but it's good enough to work around, but we don't want to go right on the scar itself. We can still work the tissue. We want to feel around and see if there's any adhesions, how thick it is underneath that scar. So our scar is about that long here, and then we have a little scope hole there if you can't tell. We want to see how far out and just with our fingers palpate where those adhesions are. And then I'm going to use the pump, so without any lotion on there at all. And I'm going to start with just a tiny little cup and applying it on slack. There's a pillow under here, so it's not completely bent and at a pull, but it's not completely flat either. But there's enough skin on here to get there. So this is an area where it's kind of hard because you got the bones sticking out. So we'll just go ahead and make sure that's okay for her. Okay. And it's far enough off, but I want to pin the tissue right next to the scar. And I might be standing in a different place if the camera wasn't here, but we're going to pin that tissue here, and then we can just stretch the tissue. That popped off, but let's go ahead. So we're going to pin the tissue next to the scar, not right on it, but right next to it, and then apply the cup to make sure that nothing dehisces the scar. So we're going to hold on to it there. Then I can do a tensile stretch, pulling in each direction. So it's not going to slide because I didn't put any lotion on her skin, but we can remove it that way. Once this gets past that stage and we can mobilize it a little bit better, I can use another cup on the other side. And I can mobilize the scar by doing a stretch. We can pull it away, give it a tensile stretch. Just first stages of working it. Then maybe I want to use a curved cup, which I don't have any here, but since I don't, I'll use the silicone cup with a little bit of lotion in here. So when I feel comfortable going right over the scar and it can be moved around, then I can go like right over the scar and just slide around, and you can feel the adhesions underneath and break them up. Just as if you would feel with the IASTM tools. And it might be a little sensitive in there as you break it apart. Doing okay? So this is kind of nice to incorporate in when we're getting a massage and they just want a little bit of attention and they really don't want to do the whole audience participation. They want to relax and get body work. And you just want to work on them in that fashion. But you can do some active dynamic motions with it as well. So we'll see if these stay on within motion. Maybe you want to get one on the other side too. Do different kinds of cupping here. And then we can even add on some more. Maybe I want to work here, and I'm going to use it without lotion on the vastus medialis. And then we'll hit one here on the vastus lateralis. And then I can have her point and flex her foot. We should feel more with the cups down here on her shin, or we can have her bend at the knee and do heel slides up and down. So I can do this for her, or I can take the pillow out and just have her do it. If you want to move your leg up and down on your own, just up to the pillow and down. And this is something we could even teach our clients to do at home on their own. This will help lengthen the tissue, and we can apply the cups and have them do about 20 reps of heel slides every day. And it'll mobilize that tissue in between massages. And you can relax. Do your aftercare. So here we have a scar, and this can affect the pelvic floor if it's never been worked on before. If you feel over it and you feel the dense tissue underneath, we can do a little IASTM or gua saw. There's a lot of fancy tools, but I like to use a mason jar lid. And we can start off just doing some strokes in a line with the scar at about a 20-degree angle. And if that's tolerable, you can always increase it to a 45-degree angle and press a little harder. And this is multi-directional to break up the fascia. You can do this on C-section scars, gallbladder, appendix, any kind of injury, stabbing, no. And with this little tool, you'll feel things that you won't feel with your own fingers. And you can break up all those little bumps in there.
Okay, there was a study done in 2015 and about some of these postnatal considerations, and was determined that basic Pilates instruction can start at 72 hours after delivery, and home programs 5 times a week for 8 weeks can significantly actually reduce postpartum maternal fatigue in acute postpartum population. So I think there is something to say that, like, you shouldn't do exercise for 6 to 8 weeks postpartum. But when you think about it, newborn care and carrying around a baby and getting in and out of a chair is some of the hardest things to do. Do laundry, lifting a car seat, the diaper bag, just all kinds of newborn care can be harder than exercise. So I don't know what they're talking about, but we don't want to do any high aerobic or running or anything like that because you could hemorrhage. You have to be careful because relaxin hormone is still in your body for 6 to 8 weeks, and we don't want to tear any ligaments and things like that. But pelvic floor and our transverse abdominis, if they co-contract and we do some bracing of our core, then it's safe to initiate immediately. So we initially treat pain to bring it down to a manageable level and then proceed with restoring function, endurance, and strength. Okay, so we have our local stabilizers, or transverse abdominis, and our pelvic floor muscles. So you can see in the photo here that our transverse abdominis originates here on the inner surface of the cartilages of the lower 6 ribs, interdigitation with the diaphragm and the thoracolumbar fascia, the anterior 3/4 of the internal lip of the iliac crest, and the lateral third of the inguinal ligament. The transverse abdominis inserts into the linea alba, the pubic crest, and the pecten pubis. You can see those areas there, so big wrapping around. The TA and the pelvic floor muscles are small muscles, and they don't have any joint play, and they work best with minimum contraction. when you work them, it's difficult to feel, and you would never try to overwork them or feel the burn, you know, like when you're doing abs for your rectus abdominis. This actually works best with breath. And, but yeah, so if you try to contract these actually at 100%, then everything else contracts too. So you have no sense of what's happening. So, for example, you contract tight and hover over your chair. If you try to co-contract your transverse abdominis and your pelvic floor while you're hovering over your chair, you can no longer feel your transverse abdominis or your pelvic floor because your legs are starting to burn, right? They also work as anticipatory contractions. So the transverse abdominis activation with limb movement. Before you even raise your arm, your body automatically, it's an automatic thing that they stabilize the spine for a movement pattern. And the transverse abdominis activates between 20 to 100 milliseconds prior to a limb movement, regardless of the direction. Transverse abdominis contraction increases the stiffness of the sacroiliac joint. When the transverse abdominis and the pelvic floor muscles co-contract, it actually increases the compressive forces at the SI joint by 400%. That's a huge amount. So, yeah, if they're having problems with their SI joint, they really need to learn how to co-contract the TA and the pelvic floor to help stabilize that, and that'll help with SI joint pain. Okay, so I'm going to have a video of us in how to find the transverse abdominis. We're going to try to palpate it. The action of the transverse abdominis is it flattens your abdominal wall and compresses the abdominal viscera, so it keeps your organs inside of your body. It increases intra-abdominal pressure, and it does not render the spine rigid. It decreases the infrasternal angle of the ribs in expiration. So as you expire, you exhale, then it contracts. It assists in the forced expiration. So if you're trying to blow out a candle, it's going to help with that. And there's no action in spinal movement for this contraction. To feel, it's easiest to do in a supine position, then we can easily feel it. And we're going to go 1 inch just inside of the ASIS, and we're going to cue them to draw in their belly with an exhale, and noting that we do not want the obliques to bulge out, so we should have a draw in with our TA. If we feel something poking out, those are the obliques. Posterior pelvic tilt, lumbar flattening, so our obliques or our rectus would be substituting if we see that happening too, so that should not be moving. And then we want to watch for the inspiration or sternal lift, so we want the ribs to draw in, not go out when someone's inhaling. So then we might have to explain paradoxal breathing. All right, so we want to do a little biofeedback, have them feel themselves while you're working on one side. They can self-palpate on the other side. We can use visual cues, like imagine putting on a corset or a girdle or Spanx, or putting on a pair of pants that are tight. And we got to suck it in to get on those tight jeans, or maybe a belt, and we want to try to do 1 notch at a time and make it tighter, or pulling our ischial spines closer together, or imagine a photo being taken. All right, so those are all our tactile cues when we're feeling for the TA. And then we have auditory cues too. So they could blow through pursed lips or a Pilates breath or any audible noise where you exhale and you actually make a sound, or you can cough. You may just go ahead and make a fake cough. You can feel your pelvic floor when you do that, or when you laugh, or when you sneeze. So those would all be examples. Let's take a look at palpating this. I have a couple videos. Here's the first one.
When you're checking for the transverse abdominis and whether it is contracting or not, the easiest spot to find it on is right on the inside of the ASIS. So if you find the hip, the edge of it, and then come around to the front, you can feel for it here. However, if you see the rib cage the way it is here, we have to have them in a neutral position to begin with. So the ribs actually have to come down, and sometimes just exposing someone's abdominal region, they'll contract their transverse abdominis anyway, so we have to give permission for them to let it all out and relax. And we might bring their arms down and have them feel along on the other side so they can get a little bit of biofeedback as well. If it's still up too high, we need to raise up the shoulders and the head. So if you just sit up a little bit, and you can pan over this way, see what I'm doing. Just gonna give it a little bit more of an incline. And as he relaxes, now you can see that the angle of the ribs is better. And so what you're gonna do to start is have them just take a really big inhale. And as you exhale, you're gonna bring in your belly button. Yeah, and then I can feel it. So what you're gonna look for is when they're inhaling, is the abdomen gonna come out, or is the chest gonna rise? Some people breathe in their chest and they do the paradoxal breathing. So what we want to do is have them realize that they need to breathe with their abdomen and visualize the diaphragm coming down as the pelvic floor comes down, and as they exhale, it comes up. And they'll start to feel the transverse abdominis is what holds all your organs in. So it's you don't have to press very hard. So if I have them on the exhale draw their belly in, you should just feel a nice pull inward. And if it doesn't go in and it comes out, that's their obliques overcompensating for it. So when they draw their stomach in, if you feel it push out with the muscles, that's the obliques. It should go in very subtly. And you can just sort of teach them how to breathe.
And then here's another one.
What I was explaining was about the transverse abdominis, and you'll see in your notes where the muscle lies and how it holds in your organs. And when you're abdominal breathing, it should come out here, and on the exhale, the transverse abdominis normally comes in. So to feel for that, you would find the ASIS and you come just medial of it. So if I go on this side and I find her hip bone and I just go in, this is actually the easiest place to find the TA because it's the area where there's the least amount of muscle overlap, so you can feel it the best in here. Once you know how to feel it, you can feel it anywhere. And so usually what I'll do is have them take a nice deep breath, and on the exhale, just really kind of audibly exhale. And I might take their hand and have them feel for the same spot on the other side. And so if they take a deep breath, you watch and make sure that it's rising here and not there. And on the exhale, when they exhale, yeah, so what we're looking for is that tissue slightly drawing in. It's very subtle and it goes in. What you might feel is when they do a deep exhale, and what I felt earlier was sometimes it comes up, and this happens in elite female athletes a lot, and men, that their obliques are actually stronger than their transverse abdominis, and when they exhale, instead of it getting drawn in, it gets pushed out, and they just can't feel where that muscle is. So one trick we can do is to go on all fours, and that way, like, say if it's a woman who's got a baby in there, and she's breathing in this position, she's actually working her transverse abdominis, because the transverse abdominis holds all your organs in. If you have a heavy baby in there, just breathing on hands and knees, breathing the way you're supposed to, and when you exhale, draw it in, you're weightlifting, trying to do it. So in this way, you take a deep breath in. It's easy to let your tummy hang down on the exhale. With the stomach here, if I lay my hand right over the stomach, I can feel when you take an inhale, it come down. And as exhale, draw your belly button in. So I can feel it there. Now I can come right inside. I'm just going to choose the side next to me and feel. And it might be easier to feel them. So I'm just going to ask permission to place my fingers right inside the ASIS and have her breathe again. There, I felt it go up. So now maybe it's just a mind-body connection and learning where those muscles are that you've never really felt before, because it's not something you go in the gym to strengthen. In fact, that makes it worse. So you work your transverse abdominis by breathing to make it stronger and holding in your organs.
So here's a pinwheel that, when the wind blows, and you can make it blow by with your breath and blowing in that. So our TA actually contracts and initiates our pelvic floor contraction or maximal contraction of the pelvic floor muscle will increase activity of the abdominal muscles, most selectively the transverse abdominis. So in this pinwheel exercise, imagine turning the pinwheel at a distance. So it's not right up close, but you have to really blow to make that thing turn. So initiate the breath though from your pelvic floor. And so you're going to fill up with air first, and then as you exhale, you want to have your pelvic floor contract up and your transverse abdominis contract inward as you blow outward. You might be able to feel that co-contraction better. Okay, so I like to think here of the tube of toothpaste when we talk about intra-abdominal pressure. When our transverse abdominis squeezes in, that's like us squeezing the tube of toothpaste. And if we don't co-contract, then the toothpaste coming out in the bottom is like a pelvic organ prolapse, right? So intra-abdominal pressure, or it could be if we sneeze or cough and we pee our pants, or we sneeze or cough and have a bowel movement. So it doesn't have to be as huge as a pelvic organ prolapse and have organs fall out of our body. But sometimes people joke about after you have a baby and you sneeze that peeing in your pants is normal. And really, it's not. It's not that we're getting older or that we've had a baby. There may have been some damage to the pelvic floor, but it's like any other muscle that if we want to get that muscle tone back, we can do that. And we want our muscles to work together as a team and to prevent things like the diastasis or diastasis recti. That's why the Valsalva maneuver while lifting or pushing, we naturally want to do that to protect our low back and to have more core stability and things like that. But if we co-contract our TA and our pelvic floor, then that's what we really need to get it back. So we need some pelvic floor muscle exercises, and the training should be done before you have a baby, and or guys before they have a prostate removed or things like that. There are also internal biofeedback devices that if there's physical therapists that you can go see and get a nice plan to follow, and highly suggest that. But if because they're more accurate and can give better exercises and monitor things. But for people who are a little bit more shy, there is some devices that you can insert and use an app on your phone and get some good feedback that way. And then if that tells you you need a physiotherapist, then you're going to need to get one. So these are just some information when dealing with postpartum women that maybe not within the scope of practice of a massage therapist, but it's good to be knowledgeable about so that if they joke around about peeing their pants, you can actually say, well, actually, there's something you can do about that and refer them to a PT. So there are superficial and deep muscles of the pelvic floor. And I do have a video that's going to show this on the pelvic model. And so with pelvic floor muscle exercises, to some degree, they all contract at once, just like I wouldn't tell you to bend your knee and only contract your semitendinosus muscle. So, you wouldn't tell somebody to just contract their left ischiocavernosus muscle. Like maybe advanced, you can just contract the anal sphincter, but that's not as important. So we just want to prevent people from, say, contracting their entire glutes and their adductors and their hamstrings all at the same time that they're doing their pelvic floor muscles. So that actually happens sometimes when you have to go to the bathroom really bad and your pelvic floor muscles are not working like they should and co-contracting with the TA. Then you start contracting your glutes and your adductors and everything else, and you do the pee-pee dance. And so we have to move beyond that at some point, right? So let's see. Let's move down here a little bit and then show you this video. And then there are the superficial muscles here. So the superficial transverse perineal stabilizes and supports the perineum. The bulbospongiosus and the bulbocavernosus, depends what book you read, that initiates erection of the clitoris and serves as a vaginal sphincter in females and assists in the urethra and assists in the erection of the penis in men. The ischiocavernosus compresses the crust, which obstructs venous return and maintains erection. So, not going to tell you to know all these muscles, but you should know their function. Here you can see where in pelvic floor instruction, if somebody's trying to contract their pelvic floor, it should rise up. So if you're sitting on a rolled up towel and you contract your pelvic floor, it should come off of the towel. Or some people might want to, in the privacy of their own home, put a finger on their perineum and then try to contract and see if that area will lift up. And then the deep muscles of the pelvic floor, you can see kind of by the name what might happen here. So these are the muscles that are inside of the bowl, where as the superficial ones are on the outside, these are the ones on the inside. The deeper layers of the pubococcygeus, right, from the pubic bone to the coccyx, the pubovaginalis, the puborectalis, right? The coccygeus moves the coccyx, so like if we had a tail. And then the obturator internus, and now we're getting into more of massage speak. So, the other ones we can kind of guess where the origin and insertion is. So the stretch of the obturator internus in the medial hip is for external hip rotation to open and tone the pelvic floor. So by strengthening the obturator internus with internal hip rotation exercises, would be to relax the pelvic floor. So if you see somebody sitting with their knees far apart, kind of straddled, you could almost assume that they have tight glutes and a tight pelvic floor, where when people sit with their legs together and their knees together and they have really tight adductors and a tight obturator internus and then more of a lower tone pelvic floor. But sometimes it's just the way they're sitting. So they're supportive and they activate as needed for postural tone required to support our pelvic organs. And for posture, contracts prior to, or the levator ani contracts prior to or with most movements to assist core stabilization. The sphincteric muscles lift inward and squeeze, and for sexual contraction during orgasms. So just so you're aware of all this. So they activate when needed for posture, meaning that these muscles are more active when we're standing than when we're sitting, and they're more active when we're sitting than when reclined. And they also have the anticipatory action. So they fire in advance, just like your TA or your lumbar multifidi or before limb moving. So there's this normal function to squeeze and then lift up. I think that's too, like when you stand at the edge of something really high up and yeah, you kind of clench a little bit. That's an anticipatory reaction, an automatic reaction. So there's a length tension relationship here with the skeletal muscle and generate different forces depending on the length of the sarcomere. The muscles work best in neutral, and too tight or too weak issues. Either way, you can't get optimal contraction strength. When one muscle isn't firing as it should, it recruits other muscles to get the job done. So yeah, that should return to neutral when not being used. Then there's this overflow principle where the ancillary muscles affect the target muscle and communicate. So there's muscle compensation, and the activation of ancillary muscles are known as this overflow activity. That's where the massage comes in with the hip abductors, gluteals, the transverse abdominis, internal obliques, obturator internus. And so an example, I know the story of this old lady wasn't walking very good, and the PT thought that it was hip weakness. So she gives a bunch of hip strengthening exercises, but really her glutes weren't firing, and she developed a bad compensation pattern in the obturator internus muscle because of it. So the obturator internus tries really hard to do what the glute muscle wasn't doing, and developed high tone in the pelvic floor. So instead of getting better, it got worse, and then she couldn't even sit. It was too painful. So she ends up going to the pelvic floor physical therapist and had to learn how to relax her pelvic floor, which eventually helped. So we don't want to assume that old people have weak pelvic floors or women who have had babies. So sometimes when there's a traumatic event, birth trauma or even abuse, sexual abuse, and all those kinds of things, that could have them holding everything way up and in. And so then they might have to learn to relax those muscles if they're having pain. So sometimes high tone and low tone can actually present similar symptoms, incontinence and or constipation or pain in the low back and or pain in their genitals and all those kinds of things. So we do have 70% slow twitch muscles, And the slow twitch would be like if there was a long line for the restroom, and those are in endurance fibers, and we have to hold it for a long time. And then we have 30% of their fast twitch, and those are the ones that contract real quickly. So, like if you do a fake cough, right? Did you feel anything? Did the organs fall out of your body? All right, so those are our fast twitch. And then we have pelvic floor activation cues that we could do. So if you're trying to, say, hold back urine or gas, imagine a real life situation. So if we maybe ate a lot of beans and we got onto an elevator and then a bunch of people got on with us and we started going up and you started feeling this and you didn't really want to offend anybody. So then we might have to hold in gas. Something like that. You want to make a real life situation. We could pull up and in, or pucker and lift, or close your anus. Sometimes gives people a sensation of where their pelvic floor is. So there's just some other things that you can try here too. And these are some pelvic floor exercises you can try too. So trying to touch your pubic bone to your coccyx. So in the beginning, when you're trying to do these, it's pretty normal for everything to just contract at once. But as you practice, you'll become more accurate, and as you repeat these exercises, but you just try to draw those bones together. Then you can try touching the two ischial tuberosities together and try to feel like the line's running only along that one direction. And with every contraction, you can do fast twitch and you can do slow twitch. So like first, one long contraction that you hold for 7 seconds, followed by relaxation. And then you can relax for like 14 seconds. And then, so you're just doubling whatever the seconds are. So if you could only hold it for 5, then you would relax for 10. But let's say you try to go for hold for 7, relax for 14, and repeat that 5 times. And then you can work on the fast twitch muscles where you do one really strong, quick contraction as hard as you can for no more than 2 seconds and then relax. Hold for 2, relax, and do that 5 times. And you want to breathe deeply on the relaxation parts. Avoid the perineum tension and help identify the lines with more precision. And then just kind of distinguish both, again, this one, then this one, and then you can try to do all of it at once. Again, doing the long endurance ones and then the quick fast twitch ones. And then you can try to do the co-contraction of the TA and the pelvic floor as you try to use the weight of your organs and draw up and in. Right, so this is just taking the entire pelvic floor and trying to raise that up. Okay, after women, after a good amount of time, at least a couple months, it's probably going to be a little bit longer than that because now they have a baby and they're going to find it hard to get into the office. But when we get a chance, we can start working on the psoas again and the iliacus. So I'm going to show you both the supine and then side lying again, because I still think side lying is best. But whatever you can do supine, you can do side lying as well. So let's take a look at this video.
Good.
So all right, recording joke. We're going to find the ASIS, and then I'll have my client point at their navel so I can find out the point in between, and that's usually where we're going to start, and we're just going to go right in, and it can be a very sensitive area. You also want to make sure that you don't feel a pulse. I usually do this skin on skin, but for demo we're doing it through the pants. Sometimes it's easier to find with a bent leg started. And you find your bony landmark and the 2 points and go in between. I sink down in, and then maybe I'll be able to feel better. If you're still not sure, you can have your client raise their leg up off of the table, and you should feel the muscle bounce back at you. If not, you can move a little bit more lateral and have them do it again, and then you should feel it. Or you could have them do a straight leg raise. So if you then have them raise their leg up, you should feel it coming against your fingertips. And I think I'm still a little bit too medial, so I'm actually a little bit way more lateral. And then tune in with them. Does that feel like I'm on it now?
Yeah.
Yeah, I can feel it. And then you can also have them put their hand on the other side in the same place, and have them do it so they have a little biofeedback, and maybe they can do it on their own at home. So for right now, we'll start with the bent leg. Right. And there's a lot of nerves and lymph nodes and stuff in this area, so instead of me digging in and doing cross fiber friction, I like to do more of an active release therapy. So I can do something as simple. If they're really sensitive, I can have them just do some diaphragmatic breathing, and when they exhale, they should feel their navel pull in towards their spine. And this way we can also check if they're breathing correctly. If they're breathing in their chest, then we can maybe teach them how, when they inhale, to breathe into their abdomen, come up, and when they exhale, their stomach should go back in. And you can feel the pressure when they inhale. It's like they're pressing right up into your pressure. You can just breathe normal. Another one that you can have them do is pelvic tilts. So if that's weird with one leg up and one down, you don't have to do that. I actually had it up for the other technique, but that I'm going to do after this. But if you want to try to do a pelvic tilt where you do a posterior tilt, go into the pressure, and anterior tilt goes away from the pressure. So this way is going deeper, and this way I'm pulling again. So I can do a little shift while she's doing a little shift. And you should breathe normally during this too. So sometimes people hold their breath. If it's too tender, then we would just lighten up. And you can relax. So those are a little bit more subtle versus I can help her bring her leg up and then just have her slide her heel down. And then she can drag her heel back up, which is harder. And you can go back down. And at the end of that, we can also have her externally rotate her entire leg out and in. Or we could have her just do straight leg raises up and down. Any of those. So I'll end it there, and then I'll show you another way to do it in a side lying position.
And then this will be the side lying video.
We can also turn the client in the side lying position. Normally when I work in a side lying position, I'll want to make sure that their hip, their knee, and their ankle are all at the same height, whether the bottom leg's straightened or if I have the pillow between the legs. It's important for their hips and low backs, for certain techniques, for them to be bolstered like this. It's also easier to find the psoas. We can do any of the techniques that we just did in the supine position in a sideline position, but when I put them side lying, I can add in a few extra things. So I can find the ASIS, and then I can just slip underneath it here and get to the iliacus, right? So follow that bone around and in, tuning in to make sure that it's not too tender for our client. I can passively do some pelvic tilts, switch hands, and put her into a posterior or anterior tilts as I do that. Or I can remove the bolster. I'm just going to set this here. And while I have pressure on that iliacus, I can have her still breathe into the pressure, or I can have her actively do pelvic tilts, or I can have her do the heel slides. So then you're just going to slide your leg down and then drag your knee back up. And this is about the right speed that you want. Or we can, at the bottom of that extension, so she's going to reach down, I can have her externally rotate her leg out and then internally rotate it. Right, so that brings in the obturator internus when we do the external rotation, the lateral rotation of the hip. And you can bring your knee back up. And I like doing this too because all the organs and everything goes down towards the table, so it's not in your way. It's also easier for, say, a female therapist to work on a male client. We don't have to worry about anything getting in the way. Everything goes down to the table and our hip is exposed here. And then I'm going to show a few things in the next video for the hip.
You can do all of those hip, the deep six, and those myofascial movements where there's some dynamic movement, the leg moving up and down, externally rotating, working all of those piriformis, gluteus medius muscles. Doing all those kinds of things really help the quadratus lumborum, all those things that we were doing in pregnancy, we can do that again in postpartum. So yeah, we just want to put that all back together, and you can do your prone supine routine again, but maybe pull out of your toolbox some of those favorite techniques from day 1 and 2 and try those out postpartum as well.